President of Arab Society of Nephrology and Renal Transplantation. دكتور طارق في حقيقة الأمر he is a former head of nephrology at Al-Azhar University and former president of the Egyptian Society of Nephrology and Renal Transplantation, ESNT. He currently holds chair of ESNT Clinical Nephrology Chapter, and he has interest in adequacy of dialysis and vascular calcification with 32 publications. He is a member of the ISN and ERA EDTA and has been on various boards of nephrology education as well as several steering committees. He has been strongly indulged in nephrology education in Egypt and through founding an outreach program and the virtual online ESNT Academy. We are very pleased to invite him today and we are ready to hear from him. The floor is yours, Professor.
Thank you very much. أولاً أحب أرحب بكل الزملاء من العراق. هذا البلد الجميل لم يسعني الحظ لغاية دلوقتي إن أنا أزوره. إن شاء الله كان صفاء وعدني إن أنا أزور أربيل، ولكن جت ظروف الكوفيد ومنعت هذا اللقاء، ولكن أدينا اهو بنلتقي مع بعض. وأنا سعيد جدا معانا الليلة الأستاذ علاء الشيخ وصفاء منورنا وكل الزملاء. شرف عظيم ليا ان انا اكون وسط زملائي من العراق، والعراق بلد له باع كبير في العلم من زمان، مش اللغة العربية والشعر فقط، ولكن العلم ده شيء معلوم للجميع. بإذن الله تكون المحاضرة ذات قيمة بالنسبة لحضراتكم.
طبعا استاذ طارق, while you are sharing your screen we are very proud انه يكون معنا استاذنا الاستاذ الدكتور علي الساعدي.
ده شرف عظيم جدا
رئيس الجمعيه العراقيه لامراض وزرع الكلى. ننتظره اكيد راح تكون الى سبيسيفيك ريماركس بعد انه حضرتك تخلص البرزنتيشن ان شاء الله.
استاذ عالم جليل وسعيد جدا بوجوده معايا وشرف عظيم ليا والله.
You can start your presentation. كلنا آذان صاغية يا أستاذنا.
How can I عاوز بس أصغر صور الفيديو دي. That's it. علشان Right. So today I want to give you some new hopes about the management, let me say, and not therapy, of autosomal dominant polycystic kidney disease. We know that ADPKD is the most common hereditary kidney disease, and it's regarded as a very important cause of end-stage renal disease worldwide, sometimes recorded as being the fourth leading cause. So you can see it's quite near to the important other major causes such as diabetes and hypertension and maybe interstitial renal diseases. The mode of inheritance, actually, it happens if an affected parent is passing the defected gene to one of his siblings. And in this diagram depicted here, you can see that the affected parent is just one. Of course, if both of the parents have the mutation in the gene, it would be a catastrophic result and all the siblings would have the disease. Usually it is just one parent that has the mutation, which may affect the polycystic kidney disease gene number 1, which is more prevalent, reaching about 90% of cases, while the PKD2 is less prevalent, reaching about 15%. Mind you, patients with the mutations affecting the ADPKD1 usually experience a much more severe phenotypic presentation, and the median age of death or onset of renal failure and requiring dialysis is rather young, reaching around 54 years, while for the PKD2, patients can survive to this end-stage renal disease up to 74 years and sometimes a little bit more. So it's a milder form of disease if you have if the patient has the mutation in the PKD2 gene. It's not just about cysts in the kidney, but this serious disease also is associated with cysts in the liver and maybe as well in the pancreas. Another serious morbid condition associated with polycystic kidney is the formation of aneurysm. And you can imagine like seeing this angiogram of the cerebral vessels if someone has such an aneurysm and the associated hypertension. So there is a really high liability for intracerebral hemorrhage. So this unfortunate patient may end up by cerebral stroke due to hemorrhage rather than end-stage renal disease. And these findings are not uncommon in this setting at all. A very common associated disease affecting all patients is hypertension, and naturally having cysts with stagnant fluid would precipitate the occurrence of recurrent urinary tract infection and nephrolithiasis, which is really troublesome to patients, not to mention the healthcare provider as well. We are faced at times with severe abdominal pains related to nephrolithiasis, and you can't give the patient proper analgesia because he's in a state of chronic kidney disease. And at times, and we really don't like that so much, and at times surgical intervention is needed to evacuate such a cyst, which is causing severe pain or causing bleeding or harboring a big stone. Now, when we look at the cyst formation, we find it's all related to the overactivity of two things: the mammalian target of rapamycin, the mTOR, and the cystic fibrosis transmembrane conductance, which is responsible about fluid passage within these cysts. And both of these proteins interplay together and regulate what's going on, leading eventually to the expansion of the renal cysts and the formation of the well-known cysts, as you can see in the picture below. So the disturbance or overactivity of the mTOR and the overexpression of CFTR are responsible for the expansion of the cysts, as I will come to show you in this slide. We have a loss of function or a mutation in either genes, whether the PKD1, which is more prevalent, or the second one, which is the PKD2. Both of these proteins really encode for a very specific protein known as polycystin, polycystin 1 and polycystin 2 respectively. And polycystin is very important for the integrity of the columnar epithelium of the renal tubules. And when the genes are mutated, the expression of this protein is also defective. Hence, the cyst formation starts to occur. Unopposed proliferation under the effects of the mTOR results in the formation of cysts, and gradually it will be separated from the original place where it was formed. And strange enough, its columnar epithelium also behaves in the same way, leading to further expansion and diffusion of salt and water through the activation of the cystic fibrosis transmembrane conductance, leads to swelling and enlargement of the cyst. And this is what eventually happens and what we see in our patients. It's not only about the mTOR, but there are other things associated or other molecules associated with the occurrence and enlargement of these cysts. The list here is very big, as you can see. I'm not going to go through all of these factors, but just to enlighten you that there are other pathways involved. Eventually, we can look at polycystic kidney disease as a case of suppressed autophagy. And suppression of autophagy plays a very important role in the formation of these cysts. And a lot of the drugs or agents used to protect against the disease are in fact inducers of autophagy. And autophagy is something very important for the physiological integrity of the human cell. And I put this slide just to remind you about autophagy, how the cell cleans itself, not only cleans itself of macromolecules and organelles and bacteria, but all of these things are eventually amino acids. The autophagy process would lead to very beneficial effect, not only cleaning the cell, but also utilizing these amino acids in the end in order to produce energy or produce new proteins or nutrition for the cell. So if the process of autophagy is defective, then the cell would not function in a proper way. And as I said, some of the therapies are directed towards enhancing the process of autophagy, which would help in ameliorating the growth of the cyst. Now, this slide, if you allow me, is very important, and I would like you to familiarize yourself with these 4 points because they are very important and related to what I have to say. We have to realize that there are no therapies for ADPKD, no therapies whatsoever, but the best of hopes is to significantly decrease the progressive expansion of the total kidney volume, meaning the enlargement of the kidney and the associated decline of the glomerular filtration rate. This can be achieved, as a matter of fact, by utilizing effective drugs with accepted adverse events, and we have to also consider the cost effectiveness of these drugs, because what I have to present to you today may be compliant with this particular word, which is adverse events and cost. Also, precision in choosing the best time to start such therapies for the right patient. This point is very critical, as it is a short statement, yes, but a very difficult one, which patient to choose and the best timing to start therapy. Not all patients with polycystic kidney disease are like each other. Some are slow progressors, some are fast progressors, some are due to mutations in the genes I showed you. Other genes are also incriminated to be associated with the disease, adding more morbidity. So picking the right patient is not always an easy task. And you can imagine, if one is going to design a specific trial to test a particular drug, to bear in mind all these variables to get significant results in the end is rather a big task. The first drug I want to talk to you about is metformin, the drug with many faces or pleiotropic effects. For more than 60 years, we've been using metformin to treat diabetes mellitus, least side effects, as you know. Maybe this point of nephroprotection is new to some of us. Definitely metformin is not nephrotoxic by all means. But as CKD progresses, we like to decrease the dosage of metformin for fear of lactic acidosis, which is not commonly met except if there are associated morbidities such as heart failure or a serious infection. Now, metformin is also used in the field of immune-mediated diseases. For a long time, it has been used to treat polycystic ovaries, another disease area, even adjuvant therapy for cancer, because it decreases the metabolism of the hungry malignant cells. So it's good adjuvant therapy, and many trials are addressing metformin in this regard, even anti-aging. And this is another talk Maybe some other time I'll be talking to you about metformin as anti-aging. And the final point is what I have to say today, how metformin could be helpful in treating ADPKD. This slide, which represents how metformin works in diabetes, is just what it is doing elsewhere. The most important point about metformin is this: it activates the activated mitogenic protein kinase C. Also, this is another pathway taking in consideration the phosphatidylcholine inositol 3 kinase is important in inhibiting the activity or the excessive expression of mTOR. So together, the activated MPK with the effects of P1, P3K would eventually lead to downregulation of the expression of mTOR, which would ameliorate the renal cell damage which is happening, whether in diabetic nephropathy or any progressive glomerular disease, and even in polycystic kidney disease. These actions would also result in autophagy initiation, which I just mentioned is very important for the integrity. So this is the secret behind metformin and how it works. Not only this, Professor Marc Dobreau, Belgium, presented this work a couple of years ago, which is really very exciting, and it was based on experimental evidence that through the activation of the AMPK signaling, metformin was able to lessen the progression of chronic kidney disease. So here you have another publication mentioning the importance of using metformin in this regard. Of course, we need more and more research in this field, and metformin, which has been regarded by some unlearned physicians, unfortunately, as nephrotoxic, is really beneficial if you know how to use it and until when. This is a very interesting experiment, and the authors used metformin to treat autosomal dominant polycystic kidney disease in diabetics, and they had some very good results, as they showed that after the first year of therapy, the GFR decreased by 2.5% in the metformin group and by 16% in controls. And this was a highly significant difference, of course, in favor of using metformin. Not only this, but even after 3 years, when they looked to their patients who were still receiving metformin, they found this difference reached 50%, denoting that or concluding that metformin is helpful in this regard. Of course, the size of this trial is not that big, so the power is not that proper. In order to have a real proper conclusion related to metformin, as I said, we need a well-designed trial in order eventually to put metformin where it should be. This is an even more exciting experiment, and the authors here started to treat the ADPKD patients who were above 18 years with metformin. They were not diabetic this time. Strange enough, they were giving patients CKD metformin with stage 5. I don't know how they could do that, but this is their methodology. They initially were giving a patient 500 milligrams per day for a month, and they increased the dose later on to 1 gram. I doubt very much that in this particular stage of chronic kidney disease, they could do that and give that too much metformin. Anyway, they concluded in the end that metformin is well tolerated and again is associated with a preserved renal function, and there was a significant decrease in the weight in the ADPKD patients after 4 months, meaning that the size of the total kidney volume started also to decrease. We need bigger trials, as a matter of fact, because this is very interesting. It's a very cheap drug with the least side effects. If it really proves to be that effective or at any scale effective, it would be really wonderful to use metformin in this regard. Now, coming to mTOR as a therapy for the disease, this is not a new thing. Two major trials were done maybe 10 years ago, hypothesizing that mTOR, as I showed you earlier, is very important in the pathogenesis of the cyst. So if we block its activity, this could be of help. And the activation of the proliferative mTOR signaling pathway was demonstrated in polycystic kidney disease of rodents and also in humans, that blocking it with sirolimus or everolimus would decrease the cysts in these animal models, including patients having the defect in polycystic kidney disease 1 or PKD2 gene. No matter which mutation, it will be effective. Hence, two large randomized clinical trials, one addressed the use of everolimus and the second addressed the use of sirolimus, were made. Unfortunately, the results were really unimpressive, and a lot of side effects happened. And this is the first one, which is the everolimus trial, which was published in the New England Journal of Medicine. And as you can see, the conclusion that within 2 years study period, as compared with placebo, everolimus did slow the increase in the total kidney volume, but unfortunately, it did not slow the progression of the renal impairment. Mind you, this result has been later on studied in the year 2012, and the possible reasons for the unimpressive nature of the human studies, generally speaking, may be due to the short duration or the high dropout rate. You can see about 32.7% of patients in the everolimus study dropped out. So this definitely, this big percentage, which is almost a third, would really affect the results. Also, suboptimal dosing, which was related to some side effects, would also affect the final result. And patients were not randomized, as I mentioned in the beginning of my talk, into fast or slow progressors. These facts altogether would really hinder the positive results that were expected. And as you see, I can't blame the mTOR inhibitors, but rather the difficulty in designing such trials are really the problem. But the fact is that mTOR inhibition does produce significant effect regarding the size of the kidney and the decline of GFR. Recently, it has been looked into the mTOR again, and to readdress it again after the past 20 years, and still the mTOR has hope to be a possible therapeutic agent to treat autosomal dominant polycystic kidney disease. And I remind you again of how it works. The mTOR inhibitor will work directly here, preventing the the proliferation of cells that will lead to renal cell damage by down-regulating the expression of mTOR. This exciting experiment thought in a much better way. Why not use mTOR together with phosphoinositol 3 kinase? Then you have two weapons to use synergistic together, and the results so far of this trial, if you are interested to read about it, seem to be very interesting. It was published 2 years ago. Now, mTOR in nephrology has more broader functions, as you would know, been using it for many years. Now, in renal transplantation, there are trials of using mTOR in diabetic nephropathy, and for surely we are all aware of the importance of using sirolimus in certain malignancies where it acts as an anti-proliferative, and it's a wonderful adjuvant therapy together with all the anti-metabolites that are used. And today I'm talking about its use for autosomal dominant polycystic kidney. The recent or the newer comer drug that came onto I mean on the stage is tolvaptan, and tolvaptan is the vasopressin V2 receptor antagonist, and tolvaptan is at present the most promising drug for treating, if you allow me to say treating, autosomal dominant polycystic kidney disease. Of course, tolvaptan was not manufactured initially in Japan for this particular reason, but it was used as a treatment for patients who have hyponatremia and those patients with severe forms of heart failure and are not urinating enough. So it's a very strong sort of diuretic, being an antagonist to the actions of the antidiuretic hormone. And by this action, it was helping and is still helping patients with these forms of intractable edema. Hence, the thought was that maybe tolvaptan would be helpful as well in this regard, which is autosomal polycystic kidney disease, and it was tried experimentally first, and now some clinical experiments and trials have been already published. You have to realize that this drug, not just it is very expensive, but it has occasionally adverse effects that could be really serious. Hypertension, renal pain, nasopharyngitis, thirst and polyuria and polydipsia are sometimes so annoying to the patients that they have to stop using the drug because polyuria would manifest during the night, causing nocturia, and this is so much troublesome to people who are not able to sleep. Every now and then they have to go to get rid of urine. So this nocturia occasionally made the patients drop out of the trials. Not to forget the serious side effect, the hepatotoxicity. So you have to be always on the watch for liver functions when you are prescribing this drug to a patient, whether he has ADPKD or something else. This is how it works. If you look at this diagram, you can see the tolvaptan here binds to the V2 receptor, and this decreases the actions of the antidiuretic hormone or vasopressin, if you wish, and hence the cyst size starts to decrease and the fluid inside is no more increasing. This is how it works. The first trial addressing the use of tolvaptan in patients with ADPKD was published 7 years ago. It was called the Tempo 3-4 trial, and the placebo group GFR decline was much more than in the tolvaptan group. So this is a very positive result. And not only that, the secondary endpoints related to this disease, such as worsening of kidney function, clinically significant kidney pain, worsening hypertension, and worsening albuminuria, all of these were better. This is the enrollment and outcomes. I will skip this one. And this graph to show you the divergence between the tolvaptan line in blue versus the placebo. Definitely there was a change in the total kidney volume as much as there was a change, a positive change or beneficial change related to the decline of GFR, which was better in the tolvaptan. Well, the introduction of tolvaptan, they claim that it may change the clinical practice in treating this particular disease. But a point, very important point to consider in terms of pharmacoeconomics, tolvaptan is very costly, and you have to consider that adding tolvaptan to a patient who already has CKD, receiving various medications, some of which are expensive, such as EPO, and you have to weigh this against the quality of life you give to the patient. Is it really worth it or not? So offsetting the high cost of therapy may be the fact that medical pain nature is going to go high when CKD progresses from stage G3 to 4 to 5, because as the patient progresses, the therapies would increase. He may be a subject of coronary atherosclerotic disease, needing angiography, maybe needing stenting or angioplasty. You understand quite well what our CKD patients are facing and the possible expensive therapies that he may need. When you are deciding to give the patient this particular drug, you have to weigh all these things and also weigh the benefits. Is it that effective? Is it really worth it? Well, I talked earlier about an important point. When is it the time to give the therapy? Regarding tolvaptan from Japan, they don't give it at this stage early, but rather in the middle when the total kidney volume is a little bit more than 700 milliliters. You have to appreciate that the normal total kidney volume in males is no more than 190 and in females 150. So by the time the patient reaches this, he has a really significant polycystic kidney. So this is the time the Japanese decided to start to initiate this treatment. You wouldn't start it here or very late over there, just in the middle. This is in accordance with the Japanese and the recommendations according to the trials. Hence, the Tempo 4 was designed, the Tempo 4 to 4 trial was designed and published recently, and this was simply an extension of the Tempo 3 to 4, adding another 2 years to get more confidence in the effects and the long-term safety of using tolvaptan. And in conclusion, regarding the Tempo 4 to 4 results, showed that it is better to use it earlier than using it late. And when I mean earlier, I don't mean here, I mean here, and late is there. So when I'm referring to early, is not at the beginning, the very beginning of diagnosis, but rather here. This is what early means. Also, it addresses the safety profile, which were not much different from that results found in the Tempo 3 to 4. Looking at the total kidney volume graph, you would see that using the tolvaptan was better if you are using it early than using late. And again, the same result, more or less. There is some significant divergence between both lines regarding the GFR decline, favoring the early use of tolvaptan. Here. Okay. We have to have some proof. We have to have some answers to certain questions. Can we give tolvaptan to all patients? The trial did raise this recent trial known as the Reprise. It questions a very important thing. Should we give it to patients who are more than 55 years when we know that older patients show an arrest of decline of GFR and maybe they don't progress? So here, this is an important question. Not all patients with the disease are subjects worthy of taking this drug that is not only costly but has a lot of side effects. So all the patients who still relatively preserve GFR tend to be slow progressors. So why worry? Why give them such a drug with serious side effects? Particularly that, as I said, there is no specific therapy. It's just an aid to prevent the enlargement of the cysts. I'm putting this slide to remind you of the side effects which may be present in 6.8% of patients that were excluded from randomization in the previous trial due to polyuria, nocturia, thirst, dry mouth, and polydipsia. it's very easy to say polyuria and nocturia, but when a patient is really having these symptoms, it's so worrisome and so difficult to deal with. Also, we have to consider that using tolvaptan may lead to hypernatremia, and hypernatremia is serious, which may lead to myelinosis, as we know. Also, the patient taking tolvaptan has to adhere with very well hydration. He has to be consuming several liters of fluids every day, which is not easy. Not to have a patient that compliant is not always easy to find. You see how designing a trial and concluding certain results, you find serious and difficult variables that would affect the results. We should always consider the surveillance of liver functions when treating patients, because I had earlier mentioned that it may affect the liver in a very serious way, and this could really do a lot of harm to our patients. Eventually, tolvaptan has been cleared by the FDA in the year 2017, and this publication was later on, and it's used now to treat autosomal polycystic kidney disease in the United States. This is an interesting work that was published last April this year, but really I can't conclude much about it because it's just a case report about two Japanese patients with autosomal polycystic kidney disease. And here the authors were courageous enough to test the much larger dose than that used in Tempo, which were using 60 milligrams per day. These authors used a higher dose, double, 120 milligrams per day for 9 years. I wish those two patients were 200 in order to have more solid evidence. Well, they did state that using the drug at this high dose and after 9 years, the patients did well regarding preservation of the kidney functions, and there was a slower increase in the total kidney volume for both patients. Well, if someone is going to try the drug with this dosage and that long, really we would have strong answers or very positive answers related to the effect of the drug. Another interesting trial here is using pioglitazone. Pioglitazone is the drug that we have been using since a very long time to treat diabetes mellitus. We understand that pioglitazone is an activator of the PPAR gamma, and this is very important because pioglitazone has been shown to be an anti-proliferative agent. And many years back, there were trials using pioglitazone to prevent the progression of diabetic nephropathy and chronic kidney disease. Well, bearing these in mind, the authors thought of using pioglitazone together with tolvaptan to have a synergistic effect, and we are still waiting for the results of this trial that is still ongoing. Maybe within a couple of years we would have some answers. This is another interesting point, and let me say this is the final point I'm addressing today, which is non-pharmacological therapies. And non-pharmacological therapies, the one that I'm going to address today is the PREVENT ADPKD trial. And PREVENT is a very interesting trial that only is giving the patients water. They have to drink large amounts of water, more than 6 liters a day. Now, billah alaykum yani, where's this compliant patient that's going to drink this much? The poor authors have really a big job in choosing these patients, and not for a day or two or a week or two. It's going to be for several years at least. And for sure, drinking this much water would have a beneficial beneficial effect. I mean, if this trial proves to be beneficial, we can consider the synergistic action of using this drinking water and the metformin and the mTOR inhibitors all together to get a more pronounced effect. There must be some guidance of therapy. You just can't go on and give this drug to anybody. So you have to follow certain classifications. I cannot go through this algorithm. It's a very complicated one. So is this, but we have to realize there are certain guidelines in choosing which patient and when, as I said before, in order to get the best results. So in conclusion, ladies and gentlemen, the conventional conservative measures in treating hypertension, infection, and other complications will always be needed, and tolvaptan, this newcomer, will not cure the disease, but we hope that it may help in lessening the burden of the disease. Metformin, a drug with many faces or pleiotropic effects, if adequate, well-designed trials are done, it could really be a good achievement because it is cheap and relatively the least side effects are related to this drug. So following the available treatment algorithms is of prime importance, and also studying the combination therapy that may synergistically tackle different mechanisms, and additional innovative medications that do not share a similar side effect profile will continue to be of interest. I want to thank you all for having me. I hope that this talk was not too long for you. And once more, I thank the committee, and I'm very happy to have Professor Ali Saidi with us tonight. Thank you.
Thank you, Professor Tarek, for this very interesting and very elegant